All right, and we just want to mention a little bit of background on RHPT. This is a project supported by the Health Resources and Service Administration and the Federal Office of Rural Health Policy. Jeannie Myers is our project officer. The purpose of RHPT is that we're designed to help strengthen organizational foundation and the key elements of value-based care, including efficiency, quality, patient experience, and safety of care. Our goal is to guide small rural hospitals and certified rural health clinics that are not currently participating in value-based care through advanced alternative payment models to prepare for and position their organizations to be effective participants in a health system focused on value. And now I'd like to welcome today's speaker, Tim Putnam. He's the CEO of Rural Health Consulting, a member of the faculty at the Medical University of South Carolina. He serves on several national boards and advisory committees as well. Tim has spent over 40 years in healthcare in a variety of roles, including laser and minimally invasive surgery research, 911 response, EMT services, hospital department leadership, and 2 decades as the CEO of community hospitals in Illinois and Indiana. He's served as president and chair of the National Rural Health Association, Rural Health Policy Congress, and the Indiana Rural Health Association. Tim lectures at several universities and speaks nationwide on the improvement of rural healthcare, transition from volume to value, healthcare governance, rural graduate medical education, policy, emergency medical services. He also has his book, Healthcare Leadership in Rural Communities, which was recently published by the American College of Healthcare Executives. So Tim, we're really happy to have you. I'm going to pull up another set of slides here. Just give me one moment.
Thank you, Molly. I appreciate the introduction. I after you read that, I feel old. Like I've been around and done stuff, and so much of that, you know, when I listen to that kind of stuff, so I remember doing that, I remember doing this, and it's interesting because there are like a lot of the folks in rural healthcare, a jack of all trades and master of none. So I'm glad to be able to speak to a bunch of folks working on value-based care in rural America. So
we're very happy to have you. Yeah, lots of history. So hopefully you can see these slides okay now.
Yes, I can. Just go ahead and start those up, and let me since we talk about me being old now, let me kind of toss out to you guys that when it comes to value-based care, especially in rural areas, we weren't allowed to be part of it. I mean, you had to have 5,000 Medicare covered lives to be involved in the first programs. And I really thought that was a mistake, and lobbied hard to be able to get us to be included in it. You know, when you sit around and think about a board meeting in an urban hospital, they're focused on how they run more heart surgery at their facility or get advanced treatment for this. When you look at rural facilities, and every one of our mission statements is virtually the same, how do we improve the health of our community? And I think that's exactly what value-based care is like that, and what it focuses on. You know, and I'm always asked to define kind of what is it. A friend of mine did it best, and feel free to steal anything that I say or put out there and use it yourself, because I certainly stole this from him. He said, value-based care is basically care that my grandmother should have received. And he said, when I was little, she had diabetes. I didn't know what that meant, but I knew that it was some sort of illness, but she could still function. I'd go to my grandmother's house and we'd play and bake cookies and all that kind of stuff. And one day I go there and she's in a wheelchair, and her diabetes had gotten worse and they had to cut off her toe. And a couple months later, I go back to my grandma's house and she's in bed because her diabetes had gotten worse and they had to cut off her leg. And he said, all along that path, hospitals and doctors were paid to diagnose the disease and cut off toes and legs, but we were never incentivized in any way to keep grandma's diabetes under control. And we just don't think like that. And we can be better than that, especially for rural facilities when we're caring for our friends and family and neighbors. So that's a little of, kind of my perspective of the general gist of what value is and what it should be. I talked to, so there was a mention of EMS in my background from that, and you can advance the slides whenever you think there's necessary. But what ends up happening is and I don't know that these are my slides, but that's okay. But that's all right. I'll keep talking, and we'll just pretend and pay attention to the to the slides as they go along. But really, when I talk to primary care docs, one of the things I mention is, do you have any patients at fall risk? And I'm like, oh yes, ton of patients at fall risk. So what are you doing about them? Well, I have them meet with the pharmacist, make sure the meds they're on aren't causing them to be dizzy or something like that. And I said, so what are their homes like? Is it safe for them to live where someone's at a high fall risk? Because what happens when we have these patients with a condition that they fall, when they do, it ends up creating a problem with hip fracture, something like that. Then they're in bed for a long time waiting to heal, and they never capture that quality of life. So it's a big deal to have a fall risk. And for an elderly patient to have a fall, and as an EMT, I've run on a lot of those patients. But the doctors don't have the ability. They don't go into the home. They don't know what's going on. And I think my litmus test of when we'll really get to value is when a physician can order a carpenter, have an order for a carpenter to go into someone's home and assess whether it's safe. And then we're really kind of starting to make that difference. So to me, that's kind of a litmus test of where we're going. The other thing I really want to talk about is data. With a lot of the value programs, depending on what you do and how you move forward, you end up getting this tremendous amount of data, but it's a bunch of stuff, and you got to sort through it. I remember working with one primary care physician. We were going through her data together, and she had the highest prescription cost. And it was significantly higher than the other docs. And she said, well, I don't know why I'm an outlier. I prescribe generics when possible. I do my best to manage that because I know my patients can't afford some of the meds and things. And what we ended up doing is kind of looking at it, and she had the highest prescription cost, but her ER visits were half that of the other docs. And what it was is her patients trusted her enough to fill the prescriptions as prescribed and take them as prescribed. And she had someone in her office, and we talked to the person in the office. Yeah, a lot of people, I talk to them, they can't afford their meds, and we find a way to make sure they get them. And stuff like that on a regular basis. You use that data and kind of figure out what's going on. Another example, and this kind of rolls into the importance of stories from my perspective of how to get everybody on board and how to change the culture of getting everyone engaged. And we did a lot of this with the care coordinators, because you'd want to come in and say, so why should I see the doctor when I'm not sick? And, that's what doctors are for. And it's like, oh, well, your doctor wants you to do this to make sure you stay healthy. So the care coordinators went through all that. And one care coordinator came to me and she said, I had a patient that said, you actually really care about me staying healthy? And, it was kind of a light bulb that went off. And it's like, yeah, we really do. We want you to be healthy. We don't just want to be here for when you're sick. And it's a real paradigm shift for the staff and for the patients and for the community to recognize that. But the thing about it is, I do want to talk about this culture change, and it requires unity. And that's why I like the stories so much, because the CEO telling the story or staff member telling a story, and the community starts to differentiate that something is different. We're doing something different about it. And it's not just taking care of you when you're sick. We're trying to fulfill our mission of creating a healthier community. And everybody's got to be on board with that, the staff, the community, and especially the C-suite. And it's tough because you've all got your deadlines, you've got your staffing issues to deal with, you've got patient complaints and things like that, but you've really got to get together and have that. And it's tough because value-based care is about preventing deaths, not saving lives. Hopefully we've all heard the three sisters Native American story where three sisters were walking along a stream and they see toddlers bobbing out in the stream. It's like, what's going on there? And one sister rushes out to the water and says, we've got to get these toddlers out of the stream. And another one says, no, there's too many. We can't get them all out. We've got to teach them to swim. They're going to be in the stream. We need to teach them how to swim. And another one starts walking upstream, and the two sisters look at her and say, where are you going? I'm going upstream to figure out who's putting toddlers in the water. And each of those roles are important, but today's healthcare system is based on pulling toddlers out of the water. And that's where the glory is, that's where the funding is, and things like that. And we really need to start thinking about who's putting the toddlers in the water. So, and it's not about better staff or better providers. It really is. It's about coordination of all things. It's about the screening, nutrition, transportation, carpentry example like I had. And the CEO is really responsible for this from my perspective, because a lot of these partnerships, I mean, as a department manager, you're not going to be able to go to a local church and say, look, we've got a lot of patients that can't get to their appointments. Is there any way you can set up a service to be able to go get those folks? And you've got to get creative to do that sort of stuff. And it takes the CEO to be able to do those things and facilitate those partnerships and follow up with them on it and tell the story of why it was a big deal for this patient to be able to get to the doctor on time and go to the pharmacy and get their medicines. Managers, this can be hard for managers because it's a real change. We're really good at what we do. And changing what we've been trained to do for so long can be difficult. I remember, part of my background was in minimally invasive surgery. So I'd work with general surgeons who were so used to doing open procedures, and I'd bring this laser or minimally invasive technique into the OR, and it was so different for them. But I've done this for years. I'm trained in this. I know how to do it, and my patients have good outcomes. Why should I change? And so it's tough. Managers, especially for ER managers and inpatient managers, all of a sudden you look around, your low census, your inpatient volume's low, and you're sending people home, and the staff is like, well, it must be all that wellness stuff we're doing, because the people that are here on a regular basis that we see kind of pretty frequently are now involved in the wellness program and not coming into the inpatient unit. So now I've got to take low census time. And it's easy for conflict to go back and forth on this. It's like, why are we doing this? I mean, this is cutting our revenue. We get a lot of money on ER and inpatient services. So why are we doing this? You got to go back to the mission. You got to go back to the stories and say, this is what the deal is and why we're part of it. So managers, it can be hard. The staff is the same way. I mean, when the staff sees that, it can be seen as a threat. Why I've got to take low census time. But it's important to be able to share the stories. And the stories that the care coordinators rarely get back up to the inpatient unit. And I think this is real important for management to be able to flesh out those stories and tell them. One of the best ones that I had is I had a care coordinator that went out to this lady's home. And you got to realize when a patient comes to us, they're in a foreign environment and it's lots of different noises and it's just not the same. But when we go to their home and do the site visits at their home and talk about things, they open up a lot more. And one of the patients was a diabetic, and she'd go to the ER because her diabetes, her numbers would bottom out or her blood glucose would get too high, but it was never managed well. And one of the nurses, the care coordinators, went to her home and said, well, show me how you test yourself. Well, and this is how to do it. And she did it. And she said, but I don't really like it because the needle hurts so much. That's a common complaint. We get that. But she said, so how often do you replace your needle? And she said, oh, I never replace that. I don't know how to replace the needle. So her needle had dulled to the point that she had to crank up the spring on this thing to be able to get blood out. And then so got to the point where she quit using it. Well, no wonder she doesn't. But you almost have to get in their home and their environment, see what they're doing, to be able to understand that we can make a difference, and how we can prevent the diabetes from getting worse or being that ER visit or that hospitalization. So much of this with staff, it's like these are my patients, this is my community, this is my hospital, and how do you get that mentality? And I think telling stories and having the staff come home with pride, we made this difference. And it's something that doesn't take high-end technology, it doesn't take fancy degrees or anything. It takes caring about our patients, caring about our friends, our neighbors, and family. Again, that's one of the things that why I love working in rural healthcare. We get to do that. So few people have a chance to take the skills that they have and make that difference for their friends and neighbors. And value is just a good way to do that. The other thing I want to talk about. Okay, I'm passionate about EMS, so I'm gonna put it out there. I EMS really has transitioned from the classic you call, we haul, that's all, to really doing some more invasive type of interventions to help people be healthy. But at the end of the day, we're kind of in EMS 2.0, where we still just take people to the hospital. We do interventions, but paramedicine or EMS 3.0 really is that kind of thing where, oh, let's see what we can do. Maybe we know the patients that are the most apt from the data and how we analyze that of making a 911 call. So maybe we go out and we do a home visit on them every once in a while. And then you start thinking about, well, what if we had this patient 12, 24 hours before they made the 911 call? What could we have done? Do they really need to go to the ER, or can they be stabilized and coordinate a visit to the primary care doc the next morning? What can be done? I was involved with a project where our OB patients were visited by EMS. And you kind of just go to the home and where's the baby going to sleep? Do you have a good crib for the baby to sleep in? What do you need to know? Let's do a regular check to make sure things are okay. And little stuff they could pick up on that might need a visit to the OB or the family practice doc that was working with them, or awareness or things of that nature, once they started getting used to it, can really make a difference. Now, there's an argument, does it really need to be 2 paramedics in an ambulance, or can it be an LPN and a Ford Focus? But I think getting this involved and getting engaged with EMS or some other type of program that mirrors paramedicine is a big difference, a big deal that we can do. Oops, sorry, that was me. The other thing I really want to hit on is the community. The community does not understand healthcare. As a matter of fact, a lot of times they disassociate from healthcare. We've alienated them for any number of reasons. People look at our hospitals and clinics sometimes as Band-Aid stations. And this is a really good way value is a really good way to engage the community. Again, it's something that you don't have to have fancy equipment. I mean, we are perfectly positioned to be engaged of this non-traditional delivery of healthcare that's involved in keeping you healthy and how to differentiate you from this large system. The CEO always goes to the Kiwanis meeting or the Rotary or the Lions meetings, and it's like, what are you doing different? And we're trying to keep our patients healthy, and this is how we're doing it, through a care coordination program, through a healthy eating aspect, to be able to do those things that don't take a lot, that really make you part of this community and fulfill your mission of helping that. So the last thing I want to do, and I really want to take questions here. I know I want to answer what you guys are challenged with, but rural organizations can lead. I really feel like, I mean, when you sit in, you listen to the board meetings at rural hospital, it's about how do we keep our community healthy? How do we fulfill our mission? How do we make this a place where my grandchildren want to be in this community? And we are much closer. We are taking care of our friends and our neighbors and our families. Uh, and I think that's really what differentiates us and what puts us in a good position. Lord help me, I really wish we were paid well for value. I will tell you that, like, one of the things that I've worked with as an example, I'm a big advocate for self-driving cars. And it's really frustrating to see self-driving cars, taxis cruise around Las Vegas or Phoenix or wherever they are. They've got buses, they've got taxis, they've got Uber all over the place. It's my small town that I need a self-driving car to go out and pick up my patients. The other thing is with vehicles today, there's about 40,000 deaths a year caused in motor vehicles. But if you think about self-driving cars and they get better and they're safer and all that sort of stuff, and we lower that down to 4,000 a year, 1/10 of the number of people dying in automobile accidents and a whole lot less being injured, what'll end up happening is a lot of people will scream, self-driving car killed my child, killed my spouse, killed my mom. You don't get a lot of value for preventing deaths. And that's really, you don't get the value of the 36,000 lives you saved. We've got to do more with value. It's got to pay better than what it does for the value we're getting out of it, for the benefits to people's lives. But I think what we're doing today is a really good first and second step. Now it'll take more steps down the road, but that's where we are. But I think we're going on the right track. Whenever I talk to people, decision makers in state houses or in Washington, D.C., they all know that we need to go down this road. There was a big analysis years ago that found an ounce of prevention's worth a pound of cure. But we pay today for pounds of cure and we don't pay for ounces of prevention. This value piece is ounces of prevention. And I hope we continue to go down that road and learn from what you guys are doing today. So that's a little bit on that. I'm happy to take questions. I know we got a couple queued up. Feel free to reach out to me by email if there's something I can do specifically for you, or answer something that I didn't address, or correct me if I'm wrong on my philosophy on value-based care. So, Molly,
Thank you so much.
I'll leave it to you. We can open up to questions however you want to do it.
Yes, yeah, and thank you. This is great information you presented on. We will, sorry,
So I
Rhonda.
have a question. Yeah, there's a question. And that is, we know that it's been fee-for-service culture in hospitals for so many years. And it's just so embedded in the way we think, and changing that culture is so difficult. So you'd mentioned things like coming back to your mission and telling stories. Can you expand a little bit more on that as far as other ways to move a culture?
Yeah, one of the things that I used to do is as a CEO, I'd meet with people having birthdays this month, and they'd be a variety of staff just sitting around. It's like, happy birthday. Okay, it's the June birthdays, and we're sitting around, and we'll have lunch, and I break off an extra kind of hour after lunch. One of the things I talk about is value and what we were doing and why we were doing it, and I pose that question, kind of like an example of patients with fall risks. And there'd be nurses there, there'd be people with elderly parents, there'd be someone that knew about someone that had a fall and really harmed just a transition from being active to now being sedentary, and all the other diseases get it. And it was a great conversation. I think that engages people so much. It's like, look, it's not going to be the smartest physician in the room that has a solution to value-based care. It's going to be a lot of perspectives from a lot of different people that care about the folks in the community and know about them, know what inhibits their ability to get care. And then you start getting these creative solutions So it's not a cookie cutter thing. It ends up being what's best for the community. And then when you do those things, and people see you kind of enacting a suggestion that they had, or coming to the community doing something different than just treating pneumonia or fixing broken bones, that's when you start to, you want the people having coffee at the coffee shop every morning talking about, when they talk about the hospital, you want them to think about that thing they're doing different, not just a shiny new surgical piece of equipment or a new building they're adding, how they're treating their mom differently. And that's what you want that conversation to be. And I think that starts it. The stories help, but getting input is a big deal.
It makes a lot of sense. Thank you. And then another question. So internally, we've been talking lately about part of the sometimes barrier for creating that culture that supports value-based care in an organization is because sometimes staff don't really realize how the work they do relates to that. And I'm just wondering what are some of your good suggestions on how to help everybody understand that regardless of their department, they play a huge part.
I think this is a really important piece to it, of engaging them that your input means something. So it's sort of like the last issue of saying, here's what we want to do, and here's what input you need from it. Part of my favorite is when non-clinical staff feel like it's their hospital, these are my patients, and this is what we're doing. My best example on that was, so we pitched this and we want people to be healthier, and we do things like that. The housekeeping department, and we had a very low infection rate at the hospital. I mean, I'm just so proud of what they did, and how they owned the component of infection rate. And they brought forth to the leadership team, now this was years ago, this was well over a decade ago, this ultraviolet device that goes in after they've cleaned it to even be more thorough about how it cleaned, how it eliminated bacteria and viruses and things like that. And it showed how it reduced the infection rate even more. Well, we had virtually zero infection rate, but still the concept was this was a big deal. So the housekeeping department, I mean, it came bubbling up from them, from some of the things they'd read or talked to their peers about. And they were excited about it because they were part of keeping patients healthy, or not having them come back or get an infection in the hospital, because they knew the people in the hospital were their friends and families and neighbors. It was great because this was unbudgeted capital piece of equipment. So I had to take it to the board, and I had one of my environmental services people come and explain what it was, how it worked, what it is, and what they wanted to do about it. And it made them so proud. And it was great because I'm setting this up for the board. It's like, it's unbudgeted capital, so you got to approve it. And they thought it was so cool to have non-clinical people be involved in the thing that makes a difference for the patient. So it's 100 things like that. But from my perspective, that's how you get them engaged and make them part of it. Again, anything you can do to have the people that work there think, this is my hospital, these are my patients, how do I take care of them better?
It's a great story. There's another question in the Q&A. You are describing public health concepts. In the hospital setting, is value-based care essentially integrating public health? Is this collaboration or integrating services? Please clarify. Thank you.
Excellent question. Public health and acute care don't mingle very well, not as well as we should. And I classify a lot of value-based care as population health, of how we're doing this together. But it's public health, but with an acute care eye. And some of this is like not how we keep healthy patients healthy, but how we keep people that are kind of on the verge of an acute episode or something healthier, a little bit farther down the timeline and the transition. And you can sort of look at it like the readmission folks, like I said, with the nosocomial infection with the housekeeping thing, or the people at fall risk. You know, they're kind of one step, and public health, just how do we keep the entire population healthy? So it's really different. But I think it's the thing that starts to bridge the gap. You know, I've got a daughter with a master's in public health, and I joke with her all the time. So okay, so you're about, you know, clean water and walking trails and farmers markets and stuff like that. And she said, yeah, that'll pretty much take care of it. And then you do everything else in your acute care world. And I'm like, okay, well, it's more than that, and it's not, but it does allow public health and acute care in the hospitals and clinics to come together and have these discussions. I think we've just got an acute care training, acute care eye on it. So it is different, but it is on the same road.
All right, thank you. I don't have any other questions in the Q&A right now. Molly, I'll turn it over to you.
Yes, we have a few things we want to hear from Tim. So you already mentioned one thing that you were proud of with the infection story. Is there anything else you're proud of related to culture or value-based care?
You know, I really am proud of what rural folks have done, because necessity is the mother of invention. So I've seen rural hospitals really get engaged, you know, with their diabetic populations, with you know, cooking classes and engaging in the farmers markets and stuff like that. I've seen that type of thing go along where it has changed the discussion in the community of how do we do that? How do we take care of the most frail? How do we keep from being that? You know, I really think getting that, when I see my staff at the hospital start thinking about that and coming up with creative solutions, that makes me very proud. I can't say better. When I talk to patients in the community and what we've done with them, not, you know, it's easy to get kind of the life-saving stuff, and I don't want to put that down. It's a big deal for the traumas and things like that. But when we prevent that bad thing from happening, I was at the International Stroke Conference a couple of months ago, and one of the presentations, you know, and endovascular stuff and the treatment of stroke really advanced quite a bit. And one physician got up and said, you know, if we just kept blood pressure under control, we'd do more than what we're doing with our high-tech mobile, you know, CT systems and endovascular surgery and all that, if we just kept blood pressure under control. And I think it's having those discussions far more than we are. That's a big deal. I get into a lot of rooms with people that said, you know, we can win on this value thing from a monetary standpoint if we just make sure we code our patients to look as sick as possible. And then we get better outcomes because we sort of worked on the scores a lot. And every time I'm in a room with people that think like that, man, I want to take a shower when I walk out. It's like, okay, yeah, we need to code them correctly, but the time we spend together and work together, especially with hospitals, kind of like we are today, of people at clinics, people at hospitals, people that are saying, how do we do this better, and looking for solutions, and coming up with real creative stuff about how do we pay for the care coordinator? How do we get them out there? How do we get them to be effective? How do we get the stories out there? That's the kind of thing we need to do to come together, not how do we chart more aggressively. So I'm really proud when I sit in a room of people like that really want to do it better and want to make a difference. And this is a hard thing because there's not a rural hospital out there that I know of that's just swimming in cash. We're all struggling. We're all trying to do more. And if we had more cash, we'd offer more services. You know, the conversations in the boardrooms, the conversations in the C-suites are, do we keep our OB unit? Do we keep cardiac rehab because we don't get paid well for that? Our home health care is really important, but we are losing money on it. So how do we keep that afloat, you know, and continue to be a viable entity and fulfill our mission with the community? Those are hard conversations. And then when I come in and say, oh, value-based care is great, it really fits the mission, and there's not a lot of cash in it, but it's a real important thing to do. When they figure out how to do it and creative ways to do it without spending a lot of money for it, that makes me really proud. I love that type of thing of how we can take this full-time person that we have to have full-time, but utilize some of their time to make calls, to schedule care coordination visits or follow-up calls after the ER, or what can we do to eliminate the readmission issue, that type of thing. It's really fulfilling. Sorry, long answer to short question.
That was great. Thank you. So the flip side of that question, is there anything looking back that you would do differently when it comes to organizational culture or value-based care?
Oh, yes. I did everything wrong to begin with. Absolutely. You know, the first year, we kind of all sat around the table and said, so how do we make the biggest impact? How do we prove that? And we were kind of, and this goes back to the public health discussion a little bit. We kind of were saying, all right, we've got this 2% of patients that absorb, you know, 30% of the cost, or slice the numbers however you want. 5% of the patients that cost 40% of our healthcare spend and Medicare and things like that. And I was really focused on those folks, kind of like keeping them out of the fire, and really kind of put my chief nursing officer, who was sort of acute care inpatient focused. So she spent all her time focused on those 2 patients. Well, the 2% that are going to cause us a problem next year are not those 2%. It's another 2%. I mean, it's the patient that you worry about that has never seen a primary care physician, doesn't watch their diet, sit around watching wrestling on television all day long. They're your heart attack waiting to happen. They're your stroke. They're your big thing. It's getting to those folks and working a little bit farther back, not back to the public health thing and everything they do, but getting farther down the line to prevent them from having the issue. And I focus too much on the acute side of just pulling people right back from the fire. You know, it's working with that diabetic patient that's got a disease, that has something going on. It's just not managing it well, and we didn't know it. So everything I did that first year was a mistake. You know, like I'll say that I made the mistake so you guys don't have to. And the programs we're putting in place now, and the programs that are involved in this this conversation or with this organization, really are the ones that have proven to be most effective, because I tried all the wrong things to begin with. Yeah, there wasn't a mistake that could have been made that I didn't make in the first few years.
Last question. What's the future of value-based care? What do you think needs to happen to in organizational culture to maybe get there?
It makes so much sense. And there's not a person that I talk to in Washington, a senator, representative, people that's like, hey, look, we need to focus on preventing disease, and this is how much we can save. The bad part about it is they always look at it from the short-term perspective. How much did we save this year? Well, you know, a lot of the stuff we're doing is not going to save money this year. It's going to save money over the next 5 years, next 10 years. And it's going to improve the quality of life of a lot of patients. And that's sort of what we're out for. So unfortunately, there's always this financial stress that people want to see this turn very quickly. I think it is inevitable. You always look in Washington what both right and left kind of agree on. I think they agree we need to put more focus on prevention of death than saving lives, and an ounce of prevention is worth a pound of cure. So I think we'll get there. We're just moving so slowly, and the people doing a lot of good work and having a lot of good outcomes really aren't paid well. I mean, you get more attention in the C-suite, you get more attention in the boardroom, the more money you put toward it. And this is one of those things that's an investment. I think this is kind of an agrarian philosophy where fee for service is sort of hunter-gatherer, where it's a bunch of hunters taking down the mastodon type of thing. And we get that. Agrarian is like, we bought the seeds, we tilled the ground, we paid people to do this, but it's going to be months. And if it's a vineyard or an orchard, it's going to be years to pay off. But everybody sees the value in it. Everybody sees the benefit of it. So I think it's long-term, it's there, it's just getting there, and it's slowly being adapted. And we know we need to move from hunter-gatherers, which is fee-for-service, to agrarian, which is value-based, but we're just going about it slowly. So I think it's inevitable, but it sure is taking a heck of a lot of time. It's tough. You sit around the campfire at your cave, and the people that went out for the mastodon, are feasting, and the people that planted seeds are looking like idiots. But the seed people win. It just takes a long time.
Thank you. Are there any other questions in the Q&A?
No, Molly, there aren't.
Okay.
I've answered all the questions. Wow. Great.
That's the feedback I'm getting.
Okay.
Well, if anyone in the audience still wants to enter a question, feel free.
Yeah, I think the last question, I'll kill time while we'll see if anybody has another question. But that's the thing. When are we going to get paid fairly for what we do with value? So we can really, again, when are we going to get paid enough that the carpenter can go in the home and make it safe for someone with fall risk? Because the math on that works really well. We do that with 100 patients. We know how many falls. We can calculate how many falls we're going to prevent in a year. But nobody right now is paying for that carpenter and all the supplies to go in and prevent that fall. I think that we just need to tell the story better. We need to continue with that, and kind of, I'm an educator at the Medical University of South Carolina, so it's publish the work, get it out there. This is what we're doing, and this is a success, and it needs to be duplicated. But there needs to be more seed money to make that happen. I don't know how many of you already have carpenters that are on call to be able to do that, but it's that type of stuff and 100 more examples just like it.
Any other last questions?
No, not right now.
Oh, great. I get to gift 10 minutes back of everyone's lives.
Well, thank you, Tim, so much for speaking. We really appreciate it. And this is an excellent topic. To those in the audience, we will be sending out a copy of the slides, so keep an eye out for that. Let us know if you have any questions in the meantime, but otherwise, enjoy your 10 minutes back and the rest of your week.
All right, everybody, thank you for all the work you're doing.
Thank you, Tim.
Thank you.
Bye.